PowerPoint presentation, maybe prick you a little for two reasons. One, we are a startup and we are yet to operationalize our offerings, and hence there is not much of the information that is available about my achievements so far in this PPT. Second, sitting here and waiting for my turn, I drank too much water. So the time between closing my presentation and rushing to the loo is getting shorter and shorter. We talked a lot about data, how we can analyze, what kind of tools we can use, how we can slice, dice, all that things. But the key question is that where is data? Do we know that if your spouse was suffering from fever 3 years back, which antibiotics worked and which antibiotics didn't? Do we know that if we were hurt and we had a fracture 5 years back, where that X-ray is lying? And next time again, if we are getting hit there, do we have access to that? So the biggest question, while health is the most important thing in our life, and that is why so many people are here, almost full auditorium here, the real challenge is we can have a lot of technology, whatever we want, but at the same time, the data that is available that can be analyzed, the data that can be utilized and called big data analytics is simply not available. Even for a single person in his lifetime, if he try to collect the data relating to health, maybe in multiples of hundreds of terabytes, but unfortunately today it is in bits and pieces. You have some prescription, some report, more than a year old, the papers you have torn, the data is simply doesn't exist and is not available from where you can recall. Second thing is medical data, healthcare data, unlike your demat account, unlike your bank statement, unlike your mutual fund, unlike your LIC policies, where there is a standards and where government is doing, financial organizations are doing to keep the data in one place, unfortunately, the institutions which are involved in providing healthcare are simply not willing to share the data. Number one, it is not standardized. Number two, nobody wants to give the data to even the patient, forget about another organization. That is another big challenge. Next is, for the healthcare institutes and service providers, there is no ownership to retain, recall, update, store, keep it safe. 5 years down the line, 10 years down the line, somebody wants to get the data, access to his data, access to his healthcare, access to his disease, access to his treatment, that is simply not available and nobody is willing to give. And lastly, while technology is available, while mobile phones are available, while best of the equipments are being brought in by clinics, hospitals and others, still I will say technology adoption in healthcare has been very, very poor. So the need of the hour is, and that is our second initiative. First initiative is e-pharmacy, and we will be coming out with that in the next couple of weeks. But our second and more important initiative is that your health should be in your pocket. We are trying to work on creating health exchange, which will make sure that we talk to the hospitals, we talk to the doctors, we talk to the paramedics, we talk to your family, we help you, we incentivize you to keep your health-related data in your own mobile, which you can access whenever you want, wherever you want. And for that, a lot of work has to be done by us, by you, and by regulatory institutes so that we can perhaps forget about standardization or analyzing the data, but at least we can create the data and we can keep the data in one place. So the initiative by us is to create health exchange, create repository of data, and make sure that you can access for you as well as your close family members. Of course, there are a lot of benefits of the big data mining. I would like to go very briefly into that, touch that the healthcare of tomorrow need to be using big data analytics, need to be personalized, need to be proactive, need to be predictive, and need to be preventative. When we say personalized, then it is not just sufficient that which particular disease can be cured by which type of medicines or which type of operation, but also how it is there with you. What is so specific about you that only one particular set of medicine or only one particular type of operation should be done by you, on you, and not something else. So what is the need is that definitely big data, once it is available, it can help in providing personalized treatment rather than generic one. Another thing is proactive. Earlier, Sanjeev Kumarji talked about we should think about those who are healthy and not only those who are about to die. So the question is that we should plan proactively not only those who are having active disease or symptoms, but also those who are at the low risk. And again, big data, amount of the data that is available can definitely provide a lot of help into those kind of segments which are at the low risk level, and things and initiatives can be taken at that stage itself. I know I'm running out of the time, so very quickly I would like to talk about predictive healthcare also. The next thing is that what we want is that we are creating our own health exchange, but what we want that let there be 500 health exchanges, health exchange platforms in this country. The amount, the population, the quality of healthcare that is there currently in this country requires enormous amount of effort, enormous amount of data, enormous amount of storage of the data and analysis on that data so that we can predict that, okay, this kind of weather is there, this kind of dengue or swine flu has started spreading, what kind of chaos it can create, and how we can make sure that we do take right kind of measures right now so that we can predict and prevent further deterioration in the health of our society. A couple of things which will be required here. We will need help from regulatory environments also. Electronic health record or electronic medical records, whatever are being called, they must be standardized. There should be certain incentives from the government to store the data and facilitate the data and easily exchange the data between one set of service providers to another set of healthcare service providers, and make sure that data creation, data restoration, updation, and exchange becomes the key priority, and that will certainly help a lot in making sure that we have preventive health care. That's all. Thank you.
Thank you so much, Mr. Bajpai. I'm sorry, we are actually running short of time. We've already crossed 10 minutes in our session, though we did start late. So probably just a field a question from the audience if there is any, otherwise we'll stop the discussion over here. Yeah.
Check. Good afternoon. Really informative session. I have a quick question for Mr. Sirish Sahai. I represent eClinical Works, and we are a leader in healthcare IT coming from United States. We are already using up-to-date. We have hundreds of hospitals who is already using the CDSS system. Do we have a drug database that we can implement in the Indian hospital market at this point of time? And integrate it with our current EMR and PM?
The database that we have is based on the journals, and a lot of the journals which are published from India are also incorporated in that. Like for example, we have a case of Kala Azar with HIV patient. There is a paper which was published by the BHU hospital, so that has been incorporated. To answer specifically on the hospital system, yes, we have. In fact, I was just telling him that, in fact, Manipal is a user of UpToDate, and we were talking. But the new change that we have brought, all UpToDate used to reside in a computer in a library. Now you can imagine that how useful that can be. So that itself is useful. But now we have that in the mobile of every person in that hospital. So that, in fact, I want to talk to you about. We can give that access based on the IP. So that that's also there.
I'm sorry, you'll have to make this question specific to analytics. Okay. So if you got something in predictive data, predictive analytics, big data, then the question is valid.
Sure, I think I'm all set. Thank you.
Okay, thank you. Easy question to do with predictive analytics and big data? Yes, Shri, sorry.
Yeah, the question is definitely about analytics. We are talking about forward-looking analytics based on big data, the data which actually will result into a decision making. My question is about the ownership of the decision, the business decision, and we are talking about life and death here. Who owns that decision? As I understand, it is based on the mathematical model. There will be some degree of accuracy involved, probabilistic analytics and all that. So it's a very basic and challenging question that I'm trying to ask. It might not be answered to the degree of accuracy that we have, but who owns that decision? Who will stand for it and who will sign for it?
I think that's a very good question, and that's what we are going through with FDA. If there is a CDSS model, which is Clinical Decision Support System model, is the decision of the model is final? If it is final, let's say it is wrong because it cannot be 100% correct, then who is liable? So for that, FDA still doesn't have an answer. So where they are saying is, if you have a retrospective analysis, like I can identify these people are going to be sicker, or this person might end up in an ICU, or this person has got higher chances of complications, then it's still vetted by the clinical pathway group or clinical committee group or IRB of the hospital. And the hospital doesn't change clinical guideline too often because you are not doing clinical trial on this part. So this is the concerning area for CDSS. So where things have got adopted now in various hospitals across the world is people are now getting benefited about predictive analytics before we are treating somebody into acute care. But acute care, even I would say, maybe CDSS has not become that effective to be helping doctors to decide whether I should ventilate now or I should not be ventilating now. But definitely for predicting, let's say, predicting sepsis earlier, predicting ICU admission earlier, predicting whether this is a stroke or not a stroke. So those kind of areas, I think it's getting there. But on the other side, I think if you understand the economic impact of it, recently Xerox launched something in New York State called fraud, abuse, and analysis. So I do see the similar issue with, let's say, many developing countries where we spend a lot of amount of money on public health, but somewhere we want to know whether the money is really reaching the intended place, whether it is reaching or not. So a very similar situation in US where doctors claim something which they should not have claimed, and we can identify this merely through data rather than, asking these difficult questions. And that has really made a big difference for New York State to adopt this. So these kind of things can definitely work in to start with, which are semi-clinical to non-clinical. And slowly, I think as accuracy improves, it will go towards clinical decision.
Thanks, Dr. Satish, but I guess we've really crossed the time. I'm sorry, we will not be able to take your question, so we'll just come down and talk to you about it. Really sorry about that. Thank you so much for participating in HIMSS, and thank you so much for a wonderful discussion.
Thanking respected delegates and chair and session panelists, we now call upon Ms. Punita Gayatri to take over.
To all of you. We are now moving to session 3, discussion on smart cities and HCIT. We kindly request Dr. Neena Pahuja, Director General, ERNT, MOCIT, Government of India, to kindly come on stage, ma'am, and please chair the session. We also welcome the panelists, Mr. Lux Rao, Country Leader, HP Future Cities and CTO, Technology Services, HP India, Ms. Kripa Gopalan, Chair, Advocacy and Policy, HIMSS Asia Pacific India, Mr. Narang N. Kishore, Mentor and Principal, Design Architect, Naning's Technolabs Private Limited, Mr. Vikram Tivantia, Deputy Director General, Cellular Operations Association of India, Mr. Gaurav Agarwal, Director, Public Sector, Cisco Systems India and SAC. Kindly please come on stage and have a wonderful discussion on smart cities and HCIT. For Mr. Neena first. So you are Mr. Lux?
Narang.
Narang. Oh, okay. So give me a moment. We need to play this. We need to play this. Yeah, I'll just I'll make the arrangements.
What you need to install fonts also, otherwise the format may get distorted.
Okay.
There are fonts in it.
Okay. So let me go ahead.
Can I do it?
Yeah, this one, because this will be running for Dr. Neena Pahuja.
Yeah, I know, but you need to first of all, so that I can once it.
Yeah. Can you just disconnect the projector for a minute? Disconnect the projector. Okay. Can you just copy this? So sorry for the confusion. They just.
Where do I put it?
Can you just put it on the desktop? Can you just put it on the desktop, please? Okay. It's done. So sorry for the interruption. Discussions may proceed. Yeah, give me that. Yeah. You want mic?